Hi, my name is Nikolai Yusupov, and in this video presentation, I would like to talk to you about electrical therapy. First, I'd like to address transcutaneous pacing, and we're going to utilize the HeartStart MRX monitor by Philips. And I like to go step by step, first outlining the basics of transcutaneous pacing, and then we're going to talk about more advanced topics with regards to transcutaneous pacing. So let's start this off with the case. Imagine you have a 65-year-old male patient who presents with altered mental status. Upon your assessment, he looks cool, pale, and diaphoretic. As you palpate his pulses, they appear to be very weak and very slow. Thus, you have a patient who presents with chest pain, shortness of breath, right, confusion, and upon obtaining his non-invasive blood pressure, it comes back 80/40. Thus, this patient has hypotension. Thus, you have all the criteria needed to determine that this patient is in shock. And also, he is placed on a 3-lead monitor, which shows you a bradydysrhythmia. In this particular case, we have a 3rd-degree heart block with AV dissociation. Thus, you have P waves that are not being conducted and QRS complexes marching on their own. So we have AV dissociation, 3rd-degree heart block, and we said if you have a patient with chest pain, shortness of breath, hypotension, confusion, means that he's not getting enough perfusion. So what is it that we're going to do? We need to emergently treat this patient. So we're going to arrive, obtain IV access, and try 0.5 milligrams of atropine to see if this will restore a more hemodynamically stable rhythm. So after your 0.5 milligrams of atropine, the patient is still in this unstable bradydysrhythmia, and your therapy was not efficacious. Thus, we need to proceed to emergently pace this person. And we're going to do this with this monitor via transcutaneous pacing. So what is it that you need to do as basic care as a paramedic? So first, you need to come in and you need to apply the 3-lead monitor. The moment you apply the 3-lead monitor, you will see that the EKG will be shown on this monitor. Another important feature that you need to apply pacing electrodes. Those are the same electrodes that you would use to either defibrillate somebody, cardiovert somebody, or to do pacing. So you place those electrodes on the patient's chest and you put your 3-lead. And the reason why this is important is because the way this monitor is designed, it will monitor the inherent heart rate via the 3-lead and provide the electrical transcutaneous pacing through the pacing electrodes. Thus, you must have both applied to the patient in order to pace this patient successfully. So the next thing that we're going to do, we're going to confirm, right? We see in lead 2, we see lead 3, we see pads, everything is functional. Go back to lead 2. And the next thing, what I'm going to do is I'm going to switch to the pacer mode. So I moved my wheel over to the pacer, and you see the following menus appear. Now we're in the pacer mode. First, and very important thing, you need to confirm that you are in demand mode. The manufacturer of this device states that this is the default mode and this is the recommended mode. If you would like to change the mode, the way you'd go about doing this, you would go to the menu, pacer mode, and then you will select the appropriate mode as your therapy. So we're going to start with demand mode. And what demand mode does is it will sense the patient's inherent heart rate and it will flag it. If you notice these spikes that appear at top of the QRS, this monitor is essentially monitoring the patient's inherent heart rate. So I see this dynamically appearing on the monitor. So I know that it's sensing the QRS complexes. I can also print a rhythm strip. And when this monitor is printing a rhythm strip, it will also mark the QRS complexes that it's sensing with markers at the top of the QRS complexes. And I'll show you how that looks like. Okay. So if you see here, right, the spikes on every QRS, the monitor has sensed that there is a QRS and it has marked it with a spike above it. So you have it in both ways. You have dynamic and you have static representation of the patient's inherent heart rate. So the next thing that you're going to do after selecting the mode, you're going to select the rate that you're going to pace this patient. Now, the manufacturer recommends you start with a rate between 60 and 90 beats per minute. 60, 90 beats per minute Or some books you will see that it's 20 to 30 pulsations per minute above the patient's inherent heart rate. So if it's 60 to 90, I can start in this case with 60 beats per minute. Or if we use the method of 20 to 30 pulsations per minute above the patient's inherent heart rate, again, I could start with 60 or 70 beats per minute. So let's start this patient with 60 pulsations per minute. And the way I go about this is I click the pacer rate. And here is where I'm going to select my pulsations per minute. That's what ppm stands for. So I could go 60, right? I'm going to check. The next button you're going to press is you're going to say to the monitor, I would like to start pacing, right? So my pacer output at this position, you want to make sure it's at the lowest setting. You don't want it to be at the max, let's say 110, right? Or whatever it will go to, and then inadvertently click start pacing, because now all of a sudden the patient is getting that full milliamps right away. And for somebody who is still able to respond, who is still, complaining to you about, let's say, chest pain or shortness of breath, this will be very, very painful. Now we want to go to the lowest setting at milliamps, right? So 10. Pacer rate we already set at 60. The next action we're going to do is we're going to commence pacing by clicking the soft key, and we're going to start pacing. The moment I click the soft key, start pacing, right, you notice I have spikes that appear, right? Spikes that appear. So the pacer mode has been activated, and the monitor is actively pacing this patient at 10 milliamps. However, it's very important that I obtain electrical capture before I can proceed to confirm my mechanical capture. So how do you know you have electrical capture? The way you know that you have electrical capture, and it's very important you understand this, is that pacing stimuli leads to depolarization of the ventricles. And the way we know there's depolarization and essentially, again, repolarization, that confirmation is confirmed by a widening QRS and, very important, a tall and broad T wave. You must have a T wave in order to confirm that you have electrical capture. I repeat that again. You must have a T wave in order to confirm electrical capture is present. So what we're going to do is we're going to increase our output slowly until we see that spike followed by a broad wide QRS with a tall T wave. And that should be for every spike that you see. So we're going to go slowly and see if we have capture. So 15, no capture. 20, still no capture. Okay. Still no capture. And the reason why you don't want to go super quickly is because you don't want to give the patient more than necessary energy, because this causes a lot of pain and they may feel burning sensation where the pads are. Their muscles will be twitching, so they'll have pain secondary to that. So you want to give them the least amount of energy in order to get electrical capture. So we still don't have capture, we're still going up, right? Still going up. And again, we're looking for that QRS complex, white QRS complex, followed by a T wave. Still no capture. So now, right, what we see is now we see the QRS followed by a tall T wave. So I'm just going to show you. What you see is pacer spike, QRS followed by a T wave. With the T wave present, it tells me that I have electrical capture. Now, what I like to do is I like to go down and still see if I have electrical capture. And the reason why this is important is I want to give the patient the least amount of energy in order to have electrical capture. So when I go down, I notice that some of my impulses are not being paced, so I don't have electrical capture. So I need to go back to 75. Once I go back to 75, I notice that my capture is again reconfirmed. So now I can say, right, in my documentation, I have a pacemaker spike followed by QRS and a tall T wave. I confirm. So this tells me that I have electrical capture. So how do I go about confirming mechanical capture? The way you confirm mechanical capture, you're going to do a few things. First, you want to confirm that they have a palpable pulse. And the palpable pulse in this patient, you're gonna try, right, central pulses, because if they're hypotensive, you may not always have the peripheral radial pulses because of their shock status. So you may start with the carotid and see if that heart rate matches. You may also feel for palpable femoral pulse, brachial pulse, and then you could go peripherally, right, for your radial pulse. Another method that you can employ is you can take a stethoscope and place it on patient's fifth intercostal space, mid-clavicular line, and you want to auscultate the apical pulse. Apical pulsations of the heart. It's direct where the heart is. And again, if it matches, right, the electrical capture, that can be another indicator that you have mechanical capture. So you could use pulses, brachial, you could use carotid, you could use femoral, apical, radial. The next thing which you want to do is with mechanical capture is you want to confirm, right, is my blood pressure improving? So you want to get a full set of vital signs. So you had your baseline set of vital signs, then you want to obtain another set of vital signs. And if your blood pressure is going up, that means that, yes, in fact, you have mechanical capture because my cardiac output is improving and blood pressure is improving. You also want to check level of consciousness. So is there a change in the mental status? So again, you want to see, right, is the patient responding to name? Does the patient know where he or she is? Is the patient aware to the surroundings? Is the patient aware to the year? So self, location, year, and events. So I would say patient's awake, alert, and oriented to X. The next thing I want to check is his skin, color, temperature, condition. Thus, if you have good mechanical capture, you should have warm skin, especially towards the periphery. You should feel good pulsations, right? Your color should become pink, right? And we said the patient was cool, pale, diaphoretic. So those signs and symptoms should be improving if you have good cardiac output, right? And the patient is now improving. Now, once you confirm mechanical capture, you could document this on your ACR, and you will initiate your transport to the appropriate destination. Now, I want to point your attention and talk about the difference between demand mode and fixed mode. So let me just stop pacing. So I'll pause pacing, and it will ask you, do you want to pause pacing? Yes, I do, right? So now we're back in the pacer mode. So this is what you need to understand. When you're in demand mode, the monitor senses the patient's inherent heart rate and it flags it. So what it will do is it will sense the heart rate and it will wait until the next interval in order to deliver the pacing output, right? Now, if the patient generates his own heart rate again at the next interval, this machine will not give him that electrical therapy or pacing, because patient is generating sufficient inherent heart rate in order for the machine to say, you know what, I'm going to wait until the next beat. And the reason why this is crucial is that this will avoid R-on-T phenomenon. And when I say R-on-T phenomenon, I mean R wave, QRS R wave landing on a T wave. And that can be disastrous on the patient because this can send the patient into VTAC or ventricular fibrillation. So let me show you how this would look like. So imagine you have a patient, right? You're in demand mode. The heart rate as is 40, and we'll go back to pacing. So we know that it was a 75 milliamps, right, capture. So I'm just going to lower it just to restore it. So we're going to resume pacing, right? And I'm going to quickly increase it to 75 in order to, again, reconfirm that I have electrical capture, right? Yes, I do. I go down 1 to see if I have loss. Yes, I have loss. Let me go back to 75. Again, I have capture. Now, look, what I'm going to do is imagine the patient's heart rate now improved, and it went on its own inherent way past the 40 that we had. So let me just fix this So let me say the patient, let's say, converted spontaneously. And here I'm going to put that patient went to sinus rhythm. And we're going to say the patient's heart improved to, let's say, 70. So I'm going to activate it. And you notice the moment I activate it, right, the machine will sense this, right? It will flag the patient's heart rate and it will stop pacing. And you'll notice that the pacing stopped on its own, right? Even though it's still in that mode. And the reason why this is important is, let's say the patient's heart rate now improves and the patient is now converted, let's say, to sinus, or the patient's heart rate went above the set pacing rate that you preset them to. I don't want the machine to pace and have this RNT phenomenon. So that's why this demand mode is great for this. But now notice, let's say the patient is now slowly deteriorating, right? And the heart starts to decrease. So as the heart starts to decrease, right, the pacer will again kick in automatically, right, and it will pace the patient in the pacer rate that we have pre-programmed it to. Now, let's see what happens when we go to the fixed mode. So let me put this patient back into a 3rd-degree heart block as we had it at a rate of 40, right? And we're gonna pause pacing. Yes. Right, so we pause pacing, and the machine now flags down, right, the inherent heart rate, as you see with these spikes here. I'm gonna go to the menu, and I'm gonna select pacer mode. I'm gonna select fixed mode, right? And you notice the fixed mode appears here. I'm gonna select my rate, right, it's 60, check, right? And I'm gonna select my pacer output. So let me go down back, right? I'm gonna resume pacing. And again, we said it was at 75 that we had capture, right? We're gonna go to 75. I see capture, I go down at 70, I lose it, I go back to 75. But notice what happens. Here, the patient still had a pulse, right? So the patient was beating at 40 beats per minute, right? Now we put this patient on a fixed mode. So in the fixed mode, it's pacing the patient what the clinician has set the rate to. So it will pace regardless of patient's intrinsic heart rate. So if the patient's intrinsic heart rate were to improve, the monitor will not care for that and it will still provide the 60 pulsations per minute as you, the clinician, has set it to. So let me show you. So imagine this patient went into sinus rhythm, and let's say his rhythm went to, say, I'm gonna make it 70 beats per minute. We're gonna activate it, right? So it's active. Now look, you see how the pacemaker still continues to pace at the heart rate of 60. And right here, specifically here, you notice this could have been RNT phenomenon, where you have a R wave landing on the T wave, the vulnerable period, right, when it's relative refractory. And this can send the patient into ventricular fibrillation or ventricular tachycardia, right? Another one right here, right? So it's very important that you place the patient in demand mode, not in the fixed mode. Now you will tell me, well, Nikolai, if we're going to pace in demand mode, what's the purpose of the fixed mode? So the purpose of the fixed mode, as it was designed for the following situations. Imagine you have a patient who has T waves that are the same size, or I would say even bigger than the QRS complexes, and the machine inappropriately senses the T waves and thinks those are the QRSs. So one solution is you could cycle through the leads to find a better representation of the QRS. However, if not, you may need to switch to the fixed mode. Another reason why the fixed mode was used is, let's say somebody is in a tachydysrhythmia. And what they would do is they would try to use transcutaneous pacing in order to terminate a tachydysrhythmia.